A great thanks to all of them. Excuse me? I think I listened something. Above, as I said, all the excellent speakers that we have with us, and great thanks to all of them who accepted our invitations. And I am sure that this will be another fruitful session. This is the third webinar for this year, organized by the Hellenic Group of Sarcoma and Rare Cancers, focusing on angiosarcoma and other malignant vascular neoplasms. And at this time point, I am delighted. I would like to welcome the first speaker, who is Professor Korkolopoulou. Dr. Korkolopoulou is the head of the first department of pathology in the National and Kapodistrian University of Athens, and she is expertised in the field of sarcomas, but as well as in the field of lymphomas and brain tumors. Dear Professor, the microphone is now yours.
Thank you for this introduction. So I'm going to close camera. Okay, so today's topic is malignant vascular tumors, which according to the existing WHO classification comprises epithelioid hemangioendothelioma and angiosarcoma. Epithelioid hemangioendothelioma forms part of the spectrum of epithelioid vascular tumors and was originally described as a tumor of intermediate malignancy, but is now classified as a malignant vascular neoplasm, albeit of lower grade than conventional angiosarcoma. It is a tumor of adults. It may arise at nearly any site, most commonly skin, somatic soft tissues, lung, bone, and liver. Histology appears identical among various sites. However, clinical presentation and prognosis appear to be dependent on anatomic location, so that cutaneous epithelioid hemangioendotheliomas are usually small and circumscribed, and provided that they are primary, non-metastatic, have an excellent prognosis, whereas lung or liver epithelioid hemangioendothelioma is a more aggressive tumor compared to soft tissue counterpart. Multifocality is quite common and is thought to result from intra-organ metastatic process. Two molecular features have been described: a recurrent WW2TR1 CAMTA1 fusion seen in the vast majority of cases associated with classic histology, and a YAP1 TFE3 fusion seen in less than 10% of the cases, which display a different histology and a different clinical behavior from classic cases. So WW2TR1 CAMTA1 rearranged epithelioid hemangioendothelioma is a tumor without obvious vascular lumen formation. Vascular differentiation is rather primitive and takes the form of intracytoplasmic lumina, often containing erythrocytes. In a significant subset of cases, an origin from a small to medium-sized vein may be seen in the periphery of the tumor. The neoplastic cells are epithelioid or slightly spindled, with eosinophilic cytoplasm and small nucleolus, without atypia and without prominent mitotic activity, growing in anastomosing cords, strands, single cells, or forming solid nests within a myxohyaline stroma resembling cartilage. Notably, there is only a sparse inflammatory infiltrate. However, 1/3 of the cases deviate from these features, displaying at least two of the following three features. That is, increased mitotic activity, moderate to marked nuclear atypia, and coagulative necrosis. For these cases, with at least two of these three features, the designation malignant epithelioid hemangioendothelioma has been proposed, although, of course, this is not a proper term, because we know that epithelioid hemangioendothelioma is malignant in each case. A better term is a grade 2 epithelioid hemangioendothelioma. Such cases bear close similarity to epithelioid angiosarcoma. On the basis of histology, as already described, and tumor size with a cutoff of 3 centimeters, patients may be segregated into three groups, three risk groups: low, intermediate, and high. However, this stratification system has not been applied in many sites. Coming to YAF1 TFE3 fused hemangioendothelioma, this is a tumor usually arising in young patients. It shows a female preponderance and is most commonly seen in the soft tissue. Notably, most patients present with multifocal or even metastatic disease. Despite this, they survive for many years. And on the basis of this particular clinical behavior, it is proposed to be categorized as a distinct entity rather than as a molecular variant of epithelioid hemangioendothelioma. Such cases differ from classic CAMTA1 rearranged epithelioid hemangioendothelioma in the sense that they display great variation in histologic patterns, which comprise the presence of a nested pattern, pseudoalveolar pattern, pseudo-vasoformative pattern, and areas resembling epithelioid hemangioma. At the immunophenotypic level, irrespective of the molecular subset, the neoplastic cells express all endothelial markers, although CD34 is less often positive. Keratins are often positive and even diffusely expressed in a subset of cases, and the same applies to D240. CAMTA1 rearranged cases display strong nuclear reactivity accompanied by a cytoplasmic, less intensive staining. The sensitivity of this stain is around 85%, and the same applies to specificity. In cases of any doubt, one should proceed for FISH using either a WWTR1 CAMTA1 fusion probe or a CAMTA1 break-apart probe, which of course is 100 sensitive and specific. On the other hand, the TFE3 rearranged subtype is characterized by diffuse nuclear reactivity for TFE3 and loss of YAP1 C-terminus expression. It is to be noted that TFE3, which is a difficult stain to assess, could be also seen in a subset of CAMTA1 rearranged cases. So YAP1 and TAS is the protein encoded by WWTR1 gene, are highly homologous proteins which constitute the end effectors of the Hippo pathway. Under normal circumstances, the so-called Hippo signal on, Hippo pathway phosphorylates the two proteins, resulting in their cytoplasmic sequestration and degradation. In the presence of the above-mentioned fusions, the two proteins evade phosphorylation and are transferred in the nucleus, where they cooperate with TEAD, shown here, to promote proliferation and block apoptosis. Interest in Hippo YAP-TAZ pathway has recently revived because of the potential as a therapeutic target. Despite these two subtypes, there is a very small minority of cases with a variant WWTR1 fusion. Such cases are a little bit peculiar. They show clear cardiac involvement. There is synaptophysin expression, although other neuroendocrine markers are not expressed. And there is usually a typical histology accompanied by aggressive behavior. With regard to the prognostic significance of the various molecular epithelioid hemangioendothelioma subsets, YAP1 TFE3 fusion is by far the prognostically more favorable alteration. Multifocality, pleural involvement, lymph node, or distant metastasis have all been associated with a significantly worse outcome. In addition, in more than 50% of the cases, secondary genetic alterations affecting common oncosuppressor genes have been identified. So this is our first clinical case, female, 48 years old, with a deep-seated soft tissue mass in the thigh. This was a consultation case, so I'm not aware of the actual size of the tumor. This is a little bit peculiar histology. There is a sclerotic stroma, collagenous stroma, within which neoplastic cells with epithelioid features and rather blunt nuclear atypia grow. Some of them have clear-cut cytoplasmic vacuoles. The appearance is at first glance quite reminiscent of sclerosing epithelioid fibrosarcoma. However, the neoplastic cells were negative for EMA and MAC4. They retained I and I1, and in the contrast, they are positive for ERG and CD31. So we proceeded for a CAMTA1, and as you can see, there is a strong nuclear positivity, followed by a less intense cytoplasmic expression. So we proposed the diagnosis of soft tissue epithelioid hemangioendothelioma, despite this unusual histology, and proceeded with FISH, which disclosed the presence of a CAMTA1 brain, verifying our impression. Next case, male, 61 years old, with multiple bilateral parenchymal lung nodules, suspicious of metastatic carcinoma. However, epithelial markers, also shown here, these are the neoplastic cells, are negative, and the same applies to TTF1 and napsin A. At first, this is a tumor compatible with a classic histology of epithelioid hemangioendothelioma. Apart from these areas in which there is formation of papillary structures by the neoplastic cells protruding into alveolar spaces. These papillary structures, of course, expressed ERG and strongly nuclear CAMTA1. So this is the commonest clinical presentation of lung epithelioid hemangioendothelioma. Immunohistochemistry is valuable for the diagnosis of this tumor. ERG is useful for the distinction of this tumor from carcinoma and other sarcomas, and CAMTA1 for the distinction from angiosarcoma. It is to be noted that epithelioid hemangioendothelioma in the lung pursues a more aggressive clinical course compared to its soft tissue counterparts. This papillary front formation projecting into alveolar spaces is responsible for the old-term intravascular bronchoalveolar tumor. It is to be noted that pleural epithelioid hemangioendothelioma is a very aggressive tumor with a spindle cell or sarcomatoid appearance, creating diagnostic pitfalls with sarcomatoid carcinoma or sarcomatoid mesothelioma, so use of endothelial markers is suggested in any spindle cell pleural tumor. Coming to epithelioid hemangioendothelioma in the bone, this is usually seen in young adults, second to third decade, mostly in long tubular bones, and lesions have this peculiar feature. They tend to cluster in the same anatomical region as shown in this axial CT. They are infiltrative, with a paucity of well-formed vascular channels. Inflammatory infiltrate is sparse, and at the clinical level, in the absence of parenchymal organ involvement, they display an excellent 10-year survival rate. So, according to this data, epithelioid hemangioendothelioma of bone behaves as an intermediate grade tumor, although formally recognized as a malignant tumor. Age, absence of surgery, and tumor locations have been associated with prognosis. It is to be noted that histological stratification systems have not been tested in bone tumors, and before diagnosing an epithelioid hemangioendothelioma of bone, every effort should be made to exclude epithelioid hemangioma. In fact, 85% of the tumors diagnosed as epithelioid hemangioendothelioma of bone finally turned out to be epithelioid hemangiomas, which in the bone are considered tumor of intermediate malignancy. Next case, a female, 57-year-old with a multiple liver lesions, clinically suspicious of metastatic carcinoma, liver needle biopsy showing the characteristic features of epithelioid hemangioendothelioma, and note the diffuse strong nuclear expression of CAMTA1. So we diagnose the hepatic epithelioid hemangioendothelioma, and for comparison, this is a similar or analogous case, a patient with a multifocal malignant vascular neoplasm arising in the liver, no primary lesion in other site, but in this case, the neoplastic cells are spindle, highly atypical, and focally line slit-like spaces and invade liver parenchyma. In this case, CAMTA1 was negative, and you can appreciate the high proliferation rate in this double stain with CD31 and Ki67. So this was a liver involvement, probably primary, by a multifocal angiosarcoma. Epithelioid hemangioendothelioma of the liver pursues a variable clinical course which cannot be predicted on the basis of histologic features. It has a distant metastatic rate around 20 to 30%, Some characteristic features typical of these tumors are at the imaging level, target sign and lollipop sign, and at the macroscopic level, the presence of capsular retraction. This is from our macroscopic specimen, which followed the diagnosis of epithelioid hemangioendothelioma in the liver. Differential diagnosis from angiosarcoma would be challenging in needle biopsies, and in such cases, CAMTA1 is valuable, being positive only in 4% of angiosarcomas. Coming to angiosarcoma, this is a heterogeneous group of malignant tumors showing endothelial differentiation. They are either primary, 56% of the cases, or secondary to irradiation, UV exposure, lymphedema, exogenous toxins, immunodeficiency, or familial syndromes, notably Klippel-Trenaunay or Maffucci syndrome, in the remaining 44 to 45% of the cases. They may arise at any site, and there are three clinical subtypes: cutaneous, deep soft tissue, and breast. These subtypes display similar morphology, but different clinical presentation, behavior, and molecular background. Angiosarcoma is uniformly considered a high-grade tumor with a possible exception of low-grade primary breast angiosarcoma. Prognosis of localized angiosarcoma appears mainly dependent on primary site and etiology, so that cutaneous and post-radiation angiosarcoma of the breast display the highest recurrence rate, and thus control of local recurrence is crucial for outcome of these cases, whereas deep soft tissue angiosarcoma, the highest metastatic rate and the shortest overall metastasis-free survival. Notably, primary cutaneous angiosarcoma displays the highest rate of lymph node metastasis among soft tissue sarcomas. Coming to the molecular background, angiosarcoma is usually associated with a complex karyotype. More than 50% of the cases display MAPK aberrations, 1/3 p53 mutations, and 1/4 CDKN2A deletion. MYC is amplified in up to 100% of radiation or lymphedema-associated angiosarcoma, as opposed to a small minority of primary angiosarcoma cases. Notably, it is absent from other non-angiosarcoma types of radiotherapy-induced sarcomas, and it is an inducer of angiogenesis by virtue of downregulation of TSP1. Thrombospondin-1 is an inhibitor of angiogenesis. In 1/4 of these cases, there is complication of FLT4 or MAMEL1. A second group of alteration is KDR mutations, which are characteristic of breast and primary angiosarcoma. And the third group is the simultaneous presence of PTPRB inactivating and PLCG1 gain-of-function mutations. PTPRB encodes a negative regulator of TIE1, and PLCG1 is a major effector of VEGF signaling. And as shown in this cartoon, molecular features are different in topological and etiological subsets, as will be discussed. So angiosarcoma is a very heterogeneous tumor also at the histological level. It may be a vasoformative or spindle, or epithelioid or solid. However, in recent years, some very peculiar cytologic subtypes have been described: clear cell, foamy, signating, or granular, which in association of the fact that they are not vasoformative or only focally vasoformative, create very severe diagnostic problems. Coming to cutaneous angiosarcoma, which is the most common of the clinical subtypes, this may be sporadic, radiation-induced, or seen in association with chronic lymphedema. Sporadic cutaneous angiosarcoma tends to affect the head and neck area of elderly men who present often with multicentric lesion. It has a very high recurrence rate and a high metastatic rate. Most commonly mutated genes: P53, KRAS, PTPRB, PLCG1. Importantly, it is a tumor with a high TMB, increased PDL1 expression, and association with a UV mutational signature. On the contrary, radiation and chronic lymphedema-associated cutaneous angiosarcoma shows MYC amplification, alterations in KIT-RET genes, downregulation of CDKN2C, low TMB, and absence of UV-associated signature. The interval between radiation treatment and diagnosis of angiosarcoma is 5 to 6 years for breast cancer and more than 10 years for cancers at other sites. In chronic lymphedema, the interval between mastectomy and axillary dissection and the diagnosis of angiosarcoma exceeds 10 years. So these are the cutaneous sporadic angiosarcoma cases. They may display a solid pattern or a vasoformative pattern. However, they are usually epithelioid with high nuclear grade and tend to massively infiltrate the dermis extending into the subcutis. In the contrary, post-radiation angiosarcoma is a tumor with a mistakenly bland appearance at low power. However, at high power, these vascular structures are lined by mildly atypical endothelial cells. This particular case arose in the breast skin of a young woman 20 years following irradiation for classical Hodgkin's lymphoma in the mediastinum, and you can appreciate CMYC expression, which is a valuable tool for the differentiation from AVL. A typical vascular lesion arises within the same clinical context, takes the form of solitary or multiple small papules, well circumscribed, which consist of an anastomosing network of variably dilated vascular spaces without prominent atypia of endothelial cells. Two subtypes have been described: the lymphatic subtype, which is the most common and which bears a resemblance to lymphangioma, situated in superficial to mid-dermis and associated with expression of lymphatic markers, and the less common vascular subtypes, typified by narrow vessels lined by attenuated or hobnail endothelial cells situated in deep dermis. An important feature is that mitosis are not seen. Ki67 index is low, and it should be remembered that in some cases, post-radiation angiosarcoma displays areas indistinguishable from AVL. AVL is not a pre-neoplastic lesion, but rather considered at risk lesion, so complete excision and close follow-up is recommended. MYC overexpression and particularly amplification are not seen in AVL, and in fact, CMYC amplification is not seen even in the common case which expresses MYC. Comparing the molecular background of AVL with post-radiation angiosarcoma, there is a low frequency of HRAS and HTET mutations in AVL without EGFR, P53, P10, or NOS1 alterations. So even by itself, identification of MYC, particularly at the amplification level, is a highly sensitive and specific marker favoring the diagnosis of post-radiation angiosarcoma over AVL. Other concerning features against the diagnosis of AVL are the large size and the deep extension of the endothelial cells. It is to be remembered, though, that MYC amplification and overexpression are not useful in differentiating benign vascular lesions from primary angiosarcoma. So this is a cutaneous angiosarcoma, lymphedema associated, but it did not arise in the upper leg, but in the lymphedematous lower leg. In this case, the patient, an old lady, had an endometrial cancer for which he had undergone inguinal lymph node dissection. And as you can see, this is a multinodular lesion. This is the macroscopic photograph from the patient. An almost solid epithelioid tumor of high nuclear grade with a focal hint of vasoformation. CMYC is strongly and diffusely positive, and the same applies to ERG. Comparing primary breast angiosarcoma to post-radiation angiosarcoma. In fact, post-radiation angiosarcoma is not a breast tumor, but a tumor which infiltrates the skin of the breast. Now, primary breast angiosarcoma is a tumor situated deep in breast parenchyma in young patients who do not deliver a history of previous radiation treatment. It is equally aggressive with its post-radiation counterpart, but differs from the latter because it is not MYC amplified, it is not P53 mutant, and in contrast, is characterized by a high frequency of KDR and PIK3CA. In addition, a subset may display PTPRB mutations. This particular case was diagnosed as primary angiosarcoma of the breast, Rosen grade 2, and you can appreciate the degree that this physoformative lesion destroys normal breast elements, which can be barely discernible at this area. And why we diagnosed this as Rosen grade 2 is because of the presence of spindle cell area, which brings into discussion Donnell and Rosen grading of breast angiosarcoma. This was proposed almost 20 years ago and is based solely on histology, so that the grade 1 cases display minimal tufting without papillary formation, solid or spindle cell areas or necrosis. Grade 2 tumors display focal papillary areas or focal solid spindle cell areas, but necrosis again is absent. And grade 3 tumors display solid spindle cell areas, necrosis, prominent and atypical mitotic activity, and prominent endothelial matillae. A more simplified two-tiered histologic grading has been recently proposed for breast angiosarcoma. Low and high-grade groups are recognized, and the only three features which appear to discriminate low and high-grade tumors are the formation of solid and spindle cell foci on the basis of 10% of tumor area. Mitotic figures are expressed per square millimeter on the basis of 10, and the presence of necrosis, which is seen only in high-grade tumors. So what about the prognostic value of grading, of histologic grading in breast angiosarcoma? Despite an earlier study of Nascimento, which in essence found no correlation with the likelihood of local recurrence in distant metastasis and death, more recent studies performed in post-radiation as well as in primary setting ascribe prognostic significance to high histologic grade of breast angiosarcoma. And finally, angiosarcoma of deep tissues. This is a tumor with a male predilection. It shows a wide age range. Adults are more often affected than children. In adults, it is located in extremities and retroperitoneum, and in children, mediastinum, heart, and pericardium. Most cases are primary. The majority are epithelioid and are by definition high grade, so we should not apply FNCLCC histological grading for these cases. This is an extraordinary case, a male 66 years old with a very large retroperitoneal tumor, which had the overall features of a schwannoma, and you can appreciate the strong and diffuse S100 expression. However, there were areas of pleomorphic epithelioid cells lining vascular spaces with a vascular phenotype. So this was a schwannoma with angiosarcomatous transformation, which may occur in retroperitoneal schwannomas. Next case is a post-radiation angiosarcoma, but which did not arise in the skin. It was a soft tissue tumor which took place in the thigh, in the same area of a patient who had a diagnosis of myxofibrosarcoma irradiated 5 years ago. And you can see that this is a vasoformative tumor, but the neoplastic cells are bizarre, have bizarre nuclei. They are strongly and diffusely positive for ERK as well as for c-MYC. Coming to bone angiosarcoma is extremely rare. Patients are usually older individuals. 1/3 of the cases have multifocal disease, which may be either primary or secondary in association with chronic osteomyelitis, previous radiation, Paget disease, bone infarction, skeletal hemangiomatosis, or associated with prosthesis. This is a difficult tumor unless one performs regularly immunohistochemistry for endothelial markers, because the majority of cases display strong and diffuse keratin immunopositivity. At the molecular level, a subset of cases have few karyotypic aberrations, and the second difference is that TGF-beta signaling is highly active as opposed to soft tissue angiosarcoma, whereas p53 inactivation, KDR mutations, and MYC amplification is seen in only minority of cases. A common feature is the inactivation of RB1 pathway in more than half of the cases. So this is a common histology of a bone angiosarcoma. We recently came across this tumor, which was seen in the femoral head and neck. Similar lesions were seen in the femur, no other primary site. The neoplastic cells are epithelioid to spindle with high nuclear grade and a vascular phenotype. This was a primary multifocal bone angiosarcoma. Coming to the end, this is a pleural tumor. The neoplastic cells are epithelioid with high nuclear grade, with focal formation of papillary structures, and other areas were solid. However, this tumor was particularly because it did express a wide array of keratins, keratin 7, keratin 19, keratin 18, but was negative for mesothelial markers as well as for TTF1 and apsin A. In addition, the neoplastic cells were positive for ERK and CD31, so this was a pleural epithelioid angiosarcoma, a very aggressive tumor with broad keratin expression. And the last case is a small bowel lesion, multifocal lesion, in the form of polypoid lesions up to 0.8 centimeter. These were seen in a male, 81 years old. These polypoid lesions corresponded to mucosal and submucosal involvement by high-grade epithelioid neoplastic cells, which were intermingled with normal epithelial cells. In some areas, there was formation of lumen. However, in other areas, the tumor was growing diffusely. The neoplastic cells were partially CK7 positive, but diffusely positive for ERG. So this is a very, very rare multicentric small bowel epithelial angiosarcoma, most likely primary. We're not aware of any other primary site. So take-home messages: a panel of vascular markers should be used in any epithelioid tumor, even if keratin positive and or multifocal. A typical histology of epithelioid hemangioendothelioma plus size have been associated with aggressive behavior and define risk stratification subsets, however, not tested in every location. Molecular subsets of epithelioid hemangioendothelioma, WWTR1 CAMTA1 in the vast majority of cases, YAP1 in TF3 in a minority of cases, and variant WWTR1 in very few cases, some of the latter with a predilection for the heart. YAP1 TF3 molecular subset shows unique clinical and pathological features and is perhaps a distinct entity. Given the wide variation of angiosarcoma histology, a high degree of suspicion is required in the context of tumor affecting sun-damaged skin of the elderly, so that we include CD31 and ERK in our immunohistochemical investigation. Even by itself, identification of MYC, particularly at the amplification level, is considered a highly sensitive and specific marker of radiation-associated angiosarcoma in its distinction from AVL, but is not useful for the distinction of benign vascular lesions from primary angiosarcoma. Angiosarcoma is by definition a uniformly high-grade tumor with the possible exception of primary breast angiosarcoma, and finally, prognosis and molecular features of localized angiosarcoma depend on the primary site and etiology. Thank you for the invitation, and I'm open to take any questions.
Dear Professor, thank you very much for the excellent presentation, which reflects a cumulative experience in the field of these special tumors. And I think everybody realized by this histological description that it is sometimes very difficult to discriminate even between malignancy, namely in hemangioendothelioma, or a benign tumor, namely an epithelioid hemangioma. I would like to tell to the audience that in today's webinar, the discussion and questions will follow immediately after each presentation. So if there are any questions from the audience, you can raise a hand and we'll discuss on it. Let me have a look at the chat as well. I don't see anything. I would like just to make a short question. According to your experience, What's your opinion on the use of these novel immunohistochemical markers such as CAMTA1 or YAP1 compared to the fluorescence in situ hybridization for the detection of these chimeric products? I mean, are there any advantages or disadvantages compared these two methods?
Well, this is certainly superior to immunohistochemistry. However, in the context of a tumor, which has the typical appearance of epithelioid hemangioendothelioma, we can omit FISH and take into account CAMTA1, provided that staining is optimal. I mean that we have a clear-cut strong nuclear signal, ignoring the cytoplasmic hue, which is often present. However, in any case which deviates from typical histology, I strongly recommend to proceed with FISH. Coming to TF3 rearranged subset, this is different. If I had only TF3, then I certainly would proceed for FISH for TF3 because TF3 is not a very reliable stain. However, if coupled with YAP1 C-terminus, I think we can accept this as a TF3 rearranged subtype.
Okay, thank you very much. And I see a question from the audience in the chat, which says that given the diversity in angiosarcoma molecular alterations, such as MYC amplification versus KDR, PTPRB mutations, do you think we are close to a true molecular subclassification that could guide therapy selection?
I'm not a fan of molecular subclassification. I only perform MYC as a stain for an angiosarcoma. The important issue is to exclude epithelioid hemangioendothelioma because angiosarcoma is a much more aggressive tumor. I think this, for therapeutic reasons, one may proceed for these particular mutations, particularly KDR or PIK3CA. But I don't think that this is necessarily a new.
I think that we lost your final words, but in total, I think the answer is quite clear. Thank you very much. I don't see anything else. Thank you very much again for the excellent talk, and I think that we can proceed now with the next speaker.
Good evening from me as well. It is a great honor to introduce Dr. Michael Wagner, who is Clinical Research Director in Sarcoma Center in Dana-Farber Cancer Institute. He's a distinguished medical oncologist with a special interest in angiosarcoma and other vascular sarcomas. I pass the floor over to our speaker.
All right, thank you very much for the invitation and especially to the last speaker for that really excellent introduction and overview of EHE and angiosarcoma. So first question, can you see my slides?
Yes, we can see them.
Okay, excellent. All right, so I will talk about the medical treatment of vascular sarcomas. These are my disclosures. And as we just heard, so vascular sarcomas and vascular neoplasms are truly a range of entities, with the most common, of course, being benign hemangiomas, and then getting into the intermediate sort of aggressiveness hemangioendotheliomas, which is another plethora of diagnoses, and then Kaposi sarcoma is kind of its own separate entity that we treat and consider entirely differently. And then on the most aggressive end of the spectrum, angiosarcomas. And for my talk, I will focus, just as in the last talk, on the more aggressive diseases, epithelioid hemangioendothelioma and angiosarcoma. First, I'll talk about EHE and then angiosarcoma, and then talk about some immunotherapy approaches specifically for angiosarcoma. But first, epithelioid hemangioendothelioma, which is an incredibly rare disease, where in the US, we looked at a database that encompasses almost all cancer diagnoses in the US, and there were just about 100 new diagnoses of malignant hemangioendothelioma per year, which is virtually entirely epithelioid hemangioendothelioma. And the incidence over time has largely stayed the same, where there's less than one case per couple of million people. As we just heard, there are a few characteristic genomic alterations, with the most common being the WWTR1 CAMTA1 gene fusion. The less common but more favorable in terms of prognosis, the other chromosome alteration that we see is this YAP1 TFE3 gene fusion. They're both involving the proteins in the hippo pathway and lead to dysregulated hippo signaling, which has some implications for potential treatments that are under investigation right now. One thing that I think is important to consider when anyone with EHE is being considered for systemic therapy is that many of these patients can actually have very indolent disease, even with metastatic disease. And observation, I would consider standard first so-called intervention. So patients can live for many, many years, even with clearly metastatic EHE, and it can just sit there indolently and be watched for years and even decades sometimes. Systemic treatment is indicated if there's clear progressing disease over interval imaging, if a patient is symptomatic, even if the lesions are stable radiographically, where EHE tends to sometimes present with a very vague systemic symptomatology of pain is probably the most common thing, but even fever, weight loss, fatigue can all be felt from an EHE. And the presence of serosal effusions, which is one of the worst prognostic indicators and suggestive of a much more aggressive disease course. Which systemic treatments do we prioritize? So there have been some case series and anecdotal information presented discussing chemotherapy, where when I think about chemotherapy for EHE, I kind of extrapolate from the angiosarcoma use. There's a little bit published, but not very much, where in patients treated with anthracyclines, which is primarily doxorubicin-based regimens, the median PFS is about 5.5 months. In patients treated with taxanes or predominantly paclitaxel, the median PFS is a little bit less, of about 3.9 months. Even though it's not chemotherapy, pazopanib is of course approved for treatment of most soft tissue sarcomas. And just mechanistically thinking of targeting the VEGF pathway for a vascular tumor, it intuitively kind of makes sense. But even then, the response rates are fairly low with a short progression-free survival. There's some suggestion that liver EHEs are more likely to respond, but even so, in one series, only 25% of patients even had stable disease as the best response. There are some other therapies that are more widely used now. So inhibitors of the mTOR pathway, specifically sirolimus or rapamycin, is gaining favorability in terms of its use, where there's some data published from the group in Milan, where they published 2 retrospective series. From the larger, more recent one, the median progression-free survival was 13 months with sirolimus, with a response rate of about 10%. There was a study through SARC looking at trametinib, the MEK inhibitor. So from some preclinical work that was done in the lab, increased signaling through the MAP kinase pathway was shown to occur in the presence of the CAMTA1 fusion especially. And this study showed that the median progression-free survival was 10 months with trametinib, but again, a very low response rate of just 3.7%. However, Actually, the majority of patients on this trial had some level of tumor reduction, with 85% actually having decrease in their tumor size, just not quite meeting the RECIST criteria for response. And also importantly, there were PROs included in this study, and they showed a significant improvement in the pain intensity and pain scores in these patients. So even though there's a low response rate, there was still clear clinical benefit that was seen. There's some data looking at interferon alpha specifically. There really isn't much data in terms of other immune therapies in EHE, but in interferon or with interferon alpha, which is a bit more promiscuous than interferon beta. So interferon alpha has some activity just in its normal functioning on endothelial cells, among other cells. And the response rates were actually quite high in one series looking at patients with hepatic EHE specifically, where more than 50% of patients actually had a response, and even greater number of patients had stable disease as best response. Again, the reported PFS rate and response rates are variable just given the limited data that exists, but the median PFS in one study with interferon alpha was also about 9 months. So at least for these three treatment modalities, mTOR inhibitors, trametinib, and interferon alpha, the median PFS is somewhere on the order of about 9 or 10 months, which is more favorable than what we see with cytotoxic chemotherapy. There are a number of investigational drugs that are being developed and are in various stages of study. Um, just thinking of the mechanism of the hippo pathway signaling and the pathogenic fusions, TEAD inhibitors were very exciting. There have been a few that are being studied. One, I believe, is actually going to be presented next month at CTOS. I'm looking forward to that presentation. But that's still very experimental, and we'll have to see what those results show. And then taking advantage of the clinical benefit that was seen with mTOR inhibition, I have a study that was actually just approved and will probably open early next year looking at nab-sirolimus for patients with EHE, where that is an albumin-bound sirolimus, just similar to how nab-paclitaxel or Abraxane is albumin-bound paclitaxel. And we're hopeful that this will have more activity than sirolimus alone, just given the distribution within the tumor that can happen with the albumin-bound version of the same active drug. So in summary, for EHE, chemotherapy can be used, but it's minimally effective, although I admittedly do use it sometimes just because sometimes we generally want to try something, and there are a small subset of patients who probably do benefit. Targeted agents like sirolimus are becoming increasingly used, and there was a consensus paper that was published not too long ago actually advocating for sirolimus as one of the preferred treatments for EHE. Immune-based therapies, especially interferon alpha, have some promising results, but again, there's a relative paucity of data, and it's not something that I've seen actually widely used. And hopefully some newer investigational agents will show more activity than what we see with currently available drugs. So moving on to angiosarcoma. Angiosarcomas, as you all know, are cancers of endothelial cells. They can come up in any part of the body, similar to EHE. And as we just heard in the last talk, about 3/4 of them are cutaneous primary tumors, and about 25% arise viscerally or in the soft tissue. About 20% of patients present de novo with metastatic disease, and there's the distinction of patients with primary angiosarcoma versus secondary angiosarcoma, with secondary angiosarcoma being patients with either radiation-induced disease or from chronic lymphedema. One thing to note is that although angiosarcoma is also very rare, it does appear that the number of cases is actually increasing. So using that same database that I looked at to estimate the number of cases of EHE in the US, we did the same thing for angiosarcoma and found that there are now more than 1,000 cases just in the US of patients diagnosed with angiosarcoma. And the incidence is actually increasing. So very slowly, but it does seem like the incidence is going up. And it's probably driven in part by an increase in the number of secondary angiosarcoma cases, especially in the breast and chest wall in women, which is presumably from an increase in breast-sparing treatment for early stage breast cancers. So it's yet to be determined if that increase is going to continue, but it is an intriguing finding. In terms of prognosis, for patients with metastatic disease, the prognosis is especially grim, where this is an older study by about 20 years now, but before some of the newer therapies and better supportive care that we have now, the median overall survival for patients with metastatic angiosarcoma was less than a year. And even for patients with localized disease, the 5-year overall survival is less than 50%. The treatment for localized disease, I would consider it standard for patients to have surgery, which is often a very large and morbid surgery. And I will make the point that especially for secondary angiosarcomas of the breast or chest wall, a radical surgery is preferred, which includes resection of nearly all, or all if possible, of the previously irradiated skin, where from our own institution we looked and showed that a more radical surgery is actually better in terms of local recurrence and just clinical outcomes than a mastectomy alone. And radiation can be considered. Of course, there's limitations in patients who have had previous irradiation, if it's a radiation-induced angiosarcoma. But for localized disease, I would consider surgery with consideration of radiation as the true standard of care. This is a talk on systemic therapies, and I would say chemotherapy is much more controversial, where my thoughts on chemotherapy for localized angiosarcoma have really evolved over time. So over the past 8 or so years, where what I've found, especially as I've moved from one institution to another, is that there are really drastically different treatment patterns and practices across different sarcoma centers, even very large volume, highly experienced sarcoma centers. The EORTC published a fairly large retrospective cohort of patients with localized angiosarcoma, suggesting there were favorable outcomes by including chemotherapy in the neoadjuvant or adjuvant setting. The chemotherapies differed. Most patients in that cohort received paclitaxel, but I would argue there's no proven benefit of chemotherapy for patients with localized disease, where if a true radical surgery can be performed, I think that's the most important intervention for anyone with a localized angiosarcoma. But even for patients who have good local control, so this is again from that EORTC series, for patients who were treated for localized angiosarcoma, more than half of patients had a recurrence within the first couple of years. And once a recurrence occurs or metastasis, that becomes much more difficult to control, of course, with local therapy, and then systemic medicines sort of take precedence. There is a long history now of patients with angiosarcoma getting treated with various chemotherapies and systemic regimens. But even then, most of the data that we have is based on case series. There were some prospective, relatively small phase 2 studies. But our data is still limited just based on the rarity of the disease and what's actually been performed and published, where with cytotoxic chemotherapies, especially taxanes, the response rate can actually be quite high, where the range of reported response rates varies quite a bit. With the Angiotax study, which was actually the prospective study here, the response rate with weekly paclitaxel was only 17%, but I just from clinical experience, think that a much, much larger number of people actually have a response. And it's just very difficult to actually truly assess by RECIST criteria responses for angiosarcoma, especially cutaneous angiosarcomas, because they can be multifocal and it's difficult to measure and quantify in a sort of repeated way. But from some of the case series, the response rates for paclitaxel or docetaxel are easily reported to be greater than 50%, and I think that's probably about true. And similar with doxorubicin, patients certainly respond, but for either of these drugs, the duration of response is fairly short, where I generally will tell patients that even for patients with responding disease, that response generally will only last for about 6 months on average. And then the tumor is resistant and we have to think about other treatments. Other cytotoxic chemotherapies are used for angiosarcoma, so I emphasized taxanes and anthracyclines, but we'll also use gemcitabine and vinorelbine, which can also have activity. But even with the activity that we see, certainly better approaches are needed. And we heard in the last talk, and there was actually a question about the molecular subtypes and can that be used to help guide treatment decisions. So first, to talk a little bit about the molecular subtypes of angiosarcoma, it was first realized in around 2009 when this was published that angiosarcomas are molecularly distinct from other soft tissue sarcomas. And this is data from microarray analysis that showed that angiosarcomas cluster separately from other soft tissue sarcomas. And then further, that there were two, in broad general terms, subgroups of angiosarcoma, which were characterized as primary and secondary angiosarcomas. And again, as we heard in the last talk, secondary or radiation-associated angiosarcomas are characterized almost always by MYC amplification, and about a quarter of them will also have amplification of FLT4, which encodes the VEGFR3 receptor. And several NGS studies have been performed on relatively large cohorts of patients with angiosarcoma. And I'm not going to go through each mutation individually, but one general characterization is that there was a high number of alterations and mutations in genes that would be expected to be involved in angiogenesis. So things like KDR mutations can happen, and there's some preclinical evidence that some of those mutations would be predicted to actually be sensitive to inhibitors of the KDR receptor, so things like pazopanib or sunitinib. I'll go into some of those trials in a few slides. There are some other alterations, so things like PTRB, PLCG1, which are all important in regulating the signaling through the VEGF receptor. So intuitively, that might make one think that targeting the VEGF pathway would be a rational strategy to try and treat angiosarcoma. So a lot of studies have been done trying to show if there's any benefit doing that. And the kind of short answer is there's some activity, but it's limited. So with bevacizumab, the response rate was only 9%, with a very short median progression-free survival, less than 3 months. With pazopanib, depending on what report or trial you look at, their response rate is somewhere on the order of 3 to 20%. And again, with a short median progression-free survival, somewhat more activity with regorafenib, which is a more promiscuous TKI, but still a response rate lower than 20% and a median progression-free survival less than 6 months. Same with sorafenib and same with sunitinib, where collectively targeting the VEGF pathway by either targeting VEGF itself or the VEGF receptor yields a median progression-free survival on the order of about 3 to 5 months, universally with a response rate of less than 20%. And I think we can conclude that there is some activity by all of these drugs that target the VEGF pathway, but responses are not very common and are generally not particularly durable. there was a trial that was actually a randomized trial completed a few years ago, asking the question, could we combine various angiogenesis targeted drugs? So in this case, specifically a drug targeting endoglin, and combining that with pazopanib, so with a TKI that predominantly blocks VEGFR2. And this was randomized, where patients either got pazopanib or got the combination of the drug, which was TRC-105 or carotuximab. And in this study, there was no clear benefit in terms of PFS with the combination over pazopanib alone. Extending a little bit further, there was at least a suggestion of some benefit, but this was ultimately deemed a negative study, and the company doesn't even exist anymore. However, one thing that I thought was important is this study showed that large, and I put large in quotes just because it's a 120 patient study, which is certainly large for angiosarcoma, but many other common cancers would consider this a small study. But this at least showed that randomized studies are possible for patients with angiosarcoma. And now to focus on what I think is the more exciting area moving forward for angiosarcoma, what are the different immunotherapy approaches that can be used? And now, again, that we have a better understanding of the molecular subtypes of angiosarcoma, one of the large first studies that actually did NGS on a large cohort of angiosarcoma patients showed that there was a subset of patients who have a high tumor mutation burden, and that those patients have a DNA damage pattern consistent with UV light exposure. So these tend to be the patients who have scalp or face tumors, especially. But because of this, we were able to add a cohort for angiosarcoma on a much larger study that was a basket trial for patients with rare cancers. And the study was testing the combination of ipilimumab and nivolumab. And on the study, we treated 16 patients with the combination, and there was a response rate of 25%, which was a bit higher than what's been reported, but very exciting to see that some patients actually do respond to the immune therapies. And importantly, so of the 4 patients who responded, 3 of them had cutaneous disease of the scalp or face, which is kind of what we would have predicted based on the prior sequencing results. One of the patients had a radiation-associated breast angiosarcoma. These are just a couple of examples of 2 of those patients who had responses. The first patient, the one on the top, actually is disease-free with a complete remission now many years after his treatment, and he's actually still in touch with me. And the second patient had a very dramatic response, but then progressed elsewhere in her body and ultimately did not do well. We were able to look at some of the molecular data from these patients, although we're actually still analyzing the correlative samples from that trial. But 7 of the patients had a just clinical assessment from physicians who had ordered sequencing either through their university panels or through various companies that do sequencing. And of those 7 patients, 2 of them were patients who had partial responses and had assessments of TMB available. One of the patients who responded had what was considered a high TMB. The other had what, at least at the time, a few years ago when we were doing this analysis, what was termed an intermediate TMB, which today I think we would consider low. 8 patients had NGS done, and all of them had multiple genomic alterations, but there was no clear pattern. It was just a smattering of mutations across all sorts of cancer-causing genes and angiogenesis genes. A few of the interesting things that we saw, there was actually one patient, and this is actually the patient who had the radiation-associated angiosarcoma of the breast that responded. She actually had an NTRK fusion, and eventually after she progressed on the ipilimumab and nivolumab, I'm told, she wasn't my patient, but I'm told she was started on an NTRK inhibitor. There were also potentially targetable alterations in BRAF and BRCA1 that were identified. Only a few of the patients had PD-L1 staining available. Two of those three had high tumor proportion scores, one with 30% and the other with 50%. So trying to take this a step further, the Alliance Cooperative Group put together this study, which is asking actually several questions all in one study. The results of both of these arms, or at least initial results, were presented at ASCO first in 2023 and then 2024. I'm going to start actually with what was presented just last year, which was the first arm, which was a randomized study asking, what if we add nivolumab, or what if we add an immune checkpoint inhibitor to standard chemotherapy with paclitaxel? And this was just presented in June, and the bottom line was that it was a negative result. There was no clear benefit looking at all patients by adding nivolumab to paclitaxel. Some hypotheses as to why this might have been. One is that we use steroids as a supportive care medicine for any patient getting paclitaxel, and that in theory could suppress the immune response. And then the paclitaxel only arm did better than expected, and we don't have a clear reason why. However, from the subgroup analyses, there was a suggestion of benefit with this particular combination, specifically in the patients with scalp and face angiosarcoma, which again is not surprising given what we now know about the mutation patterns and the likelihood of these patients to have a higher TMB. The second arm of this study was taking advantage of some other preclinical data developed first in other tumor types like melanoma, showing that inhibiting the VEGF pathway might actually increase the efficacy of immune checkpoint inhibitors by modulating the immune microenvironment and increasing infiltrating T cells. So this arm 3 was actually presented a couple of years ago, looking at the combination of cabozantinib and nivolumab. And it was a small study, single arm, that enrolled 21 patients. 12 of them had tumors of the scalp or face, and 13 of those 21 patients had an objective response for a response rate of 62%, which is much higher than we would have expected with just immunotherapy alone. And importantly, there were responses seen also in patients with non-cutaneous disease, which has been reported certainly both anecdotally and then also as kind of isolated cases in other studies. But here the response rate seemed much higher than we would have otherwise guessed. The median progression-free survival in the single-arm study was 9.6 months. So again, somewhat favorable compared to what we see with cytotoxic chemotherapy. And the overall survival was actually much better than what was reported 20 or so years ago, where the median overall survival in this sort of refractory group of patients was over 20 months, which is, again, a large improvement from prior data. This same combination has been studied in other trials. I highlight just one, looking at the combination of sunitinib and nivolumab, which was for many different types of sarcomas, but there were 5 patients with angiosarcoma included in this relatively small study, and 2 of the 5 patients responded. So that, at least to a certain degree, confirms that there's activity of the combination, although again, this was a small number of patients. What are some newer approaches? So these are kind of generic figures of bispecific antibodies and antibody drug conjugates, where there are a lot of these entities being developed by various drug companies and could potentially be used for angiosarcoma, but none that really have data that I can report at this point in time. There was at least one study of a VEGFR2 targeted CAR T cell, which was a very small study. It closed after 5 patients, and there were no responses. And this was published a number of years ago. But that's a drug that, or a cell product that intuitively might make sense for angiosarcoma, but at least as of now is not being further developed. And then sort of the last molecular entity that I want to highlight is a different type of bispecific antibody, so different from the T-cell engagers that most people are familiar with and that are used for especially heme malignancies, as well as now in trials for primarily synovial sarcoma and myxoid liposarcoma. But there are other bispecific antibodies that target VEGF and PD-1. And these are currently actively being studied in angiosarcoma. None of those results have been reported yet, but hopefully we'll get some of those results soon in the next year or two. So to conclude, chemotherapy can lead to responses for patients with angiosarcoma, but those responses are not durable. VEGF pathway inhibitors have some limited activity, but again, not as much as we might hope for vascular sarcoma. Immunotherapies certainly are effective for a subset of patients with cutaneous angiosarcoma, especially. Combinations such as the VEGF inhibitors and immune checkpoint inhibitor combinations are very likely to improve the benefit that we see from systemic therapies and how to adopt them. And then also that raises the question of just drug approvals for rare cancers, which is a much larger topic than I can touch on right now. But I think rational combinations are probably going to be the path forward. So I'm happy to take any questions.
Thank you very much, Dr. Wagner, for your excellent presentation. Do we have any question from the audience? Just a minute. I can't see any question for the time being, so I will start asking one concerning angiosarcoma, high-grade angiosarcoma. In your practice, do you give neoadjuvant or adjuvant chemotherapy? And if yes, with which drug?
Yeah, so an interesting question, and I was intentionally vague in my slides because my practice has really evolved over time, and especially as I went from one institution to another, where I trained and I did my oncology fellowship, they very much believe in neoadjuvant chemotherapy, where if I am going to give it, I will generally give Taxol or paclitaxel, particularly for cutaneous disease, because you can see in real time if there's a response. And paclitaxel, on average, I would say has a fairly high response rate. I've moved away from doing that because at my current institution, the surgeons are much more likely to perform a very aggressive, radical surgery, and the outcomes from that are actually quite good. So I've become a believer that radical surgery is probably the most important thing for patients with localized angiosarcoma. If there's a tumor that is maybe crossing the midline, then it might make the difference of converting them from unresectable to resectable. I'll certainly give chemotherapy to try and do that. And then especially because the response rates are actually fairly high, that's something that we'll do not infrequently, but I'll give neoadjuvant paclitaxel and then reconsider surgery for patients where there's either oligometastatic disease or if there's a question of whether resection is possible. I have a strong preference if we're going to give chemotherapy in the localized setting, that'd be neoadjuvant. Because in the adjuvant setting, you're exposing patients to a lot of toxicity with uncertain benefit. But again, I think it's an evolving field, and I've actually been very surprised at the heterogeneity in treatment practices, even at very experienced high-volume sarcoma centers.
Thank you very much. I think it would be interesting to perform a randomized trial on the use of neoadjuvant chemotherapy in localized angiosarcoma.
I agree. I would love to do that.
Because we don't have this data.
Yeah, no, absolutely,
there is
I
a
agree.
question from Evangelia Karasteriou for Dr. Wagner. As angiosarcomas adapt to anti-VEGF or immune pressure, what resistance mechanism do you most frequently observe? For example, vascular mimicry or immune exclusion? Are there promising strategies in development to overcome these adaptive phenotypes? Thank you very much for such a clarifying presentation.
So thank you for the question. I wish I had a good answer. I don't think we really know what the resistance mechanisms are, especially for patients who have responded to any of these drugs. For example, someone who might respond to VEGF inhibitor or something like pazopanib, I think there's probably just downstream alterations. And one potential example is the PLCG1 mutation, which is seen in about 10% of angiosarcomas, is just downstream from the VEGF-R2 receptor and leads to canonical increased signaling through the VEGF pathway, including MAP kinase signaling. So I've proposed a clinical trial that hopefully will get approved, although I don't know, trying to use a combination of a MEK inhibitor with another pathway that from some of my preclinical work seems to be relevant, so specifically the Wnt signaling pathway. But I don't know if that study is going to happen. I hope it does. As far as immune therapies, again, I don't think we know what the mechanisms of resistance are. It could be many different things. So things like downregulation of, or upregulation, I guess, of PD-L1, might just kind of supersede any activity. But again, I don't think we know is the real answer. I think macrophages also are probably highly relevant, where in addition to the just immunogenic microenvironment that we see, there are also a lot of immune suppressive cells in the microenvironment of angiosarcomas. But I think that's also why the combinations are probably going to be more successful. And I think that's in part why we see such a high response rate with the cabozantinib nivolumab combination, because in theory, at least, it's modulating the microenvironment to create a more T-cell favorable response.
Thank you very much. And I have a last question concerning immunotherapy. We saw the nice results in cutaneous angiosarcoma, scalp phase, or the radiation-induced one. In your practice, do you give immunotherapy to these patients after performing NGS to check for TMB, or you give it in these subtypes of angiosarcoma without NGS?
So that's another good question. We'll typically try and get NGS, just since we're an academic institution, and I think it's good information to have. If I do have it, it might help me in terms of prioritizing when I would use an immunotherapy. But the reality is I don't use NGS as the ultimate determinant of if I'm going to recommend an immune checkpoint inhibitor to someone with angiosarcoma, where especially for patients with scalp or face cutaneous tumors, regardless of what any sequencing might show, I do tend to prioritize using checkpoint inhibitors. I'll still use chemotherapy first, but if they've progressed on chemotherapy, then checkpoint inhibitor is generally the second thing that I would recommend for probably anyone with an unresectable, especially scalp or face tumor. For patients with angiosarcomas of other sites, I'll still use the immune checkpoint inhibitors. I've started trying to implement the cabozantinib nivolumab combination, just given the high response rate that was seen for angiosarcomas of any site. And we've generally been able to get it covered, but it's certainly not guaranteed, which can be a challenge because these drugs are very, very expensive.
Yeah, that's true. Thank you very much. I don't see any other questions. So, Dr. Wagner, thank you very, very much. And
thank you.
Dr.
Thank you, Dr.
Menus,
Wagner. Thank you very much for your presentation. It's a real pleasure to introduce Dr. Yvonne Scrage from the Netherlands Cancer Institute. She's a surgical oncologist, and we met at the Royal Marsden Hospital as fellows for sarcoma patients. Yvonne, hi. She's thriving at the Netherlands, and we're going to hear about the surgical perspective for these vascular tumors, especially angiosarcomas. Yvonne, the floor is yours.
Thank you. I will start with sharing my screen. Let me see. There it is. One moment. Are you seeing my slides at the moment?
Yes.
Yes.
Okay, perfect. Thank you for the kind invitation to speak about angiosarcoma. Thank you for the kind introduction. I work as a surgical oncologist in the Netherlands Cancer Institute, and I will try to convince you to use neoadjuvant chemotherapy before doing your surgeries. And I will speak about surgical techniques for angiosarcoma. So you probably heard this in the previous talk, but there are various subtypes of angiosarcoma, the primary or idiopathic angiosarcoma and the secondary angiosarcoma, which can be caused by ultraviolet, and is merely in the head and neck region, can be caused by chronic lymphedema, in the Stewart-Treves syndrome in the extremities, and caused by radiotherapy, merely in the breast, but can also be after radiotherapy for rectal carcinoma or cervical carcinoma. So the first thing I always emphasize is that it's really important to do a biopsy when you see a bruise of the breast after carcinoma of the breast and radiotherapy, because normally bruises don't occur spontaneously. So always perform a biopsy, and if it's negative, do it again if you see some spontaneous bruise on the breast. And it can look like this, and you can see in the MRI scans a thickening of the skin, and sometimes you see some avidity in the PET scan. I would like to start with all these various subtypes. There was a nice overview, which was from the patients in the Royal Marsden from Rotterdam in the Netherlands and our institute, and they collected almost 300 angiosarcoma patients retrospectively. And there were 253 patients that went for surgery, and 233 with localized disease. And most of them were radiotherapy-associated angiosarcoma. And there were only 9 of these with Stewart-Treves and 43 UV-induced. But the most important thing is that they all have a very bad prognosis, as you can see in these Kaplan-Meier curves. So the overall survival is of the total group is 50% in 5 years, which is pretty bad. And similar for local recurrence-free survival and distant metastasis. And it's the same for all these subtypes. Let's focus first on radiotherapy-associated angiosarcoma of the breast. It's rare, but it occurs in 1 in 1,000 or 1 in 500 patients that have been treated with radiotherapy for breast cancer. Also, other subtypes of sarcoma can occur after radiation, for example, sarcoma NOS or undifferentiated pleomorphic sarcoma, MPNST leiomyosarcoma, and they have a very bad overall survival in the historical cohorts. In my institute, a systematic review was performed some years ago for neoadjuvant systemic treatment in angiosarcoma, and there are no randomized controlled trials actually. We found 18 case reports and 6 retrospective cohorts, and they all showed improvement in resection margins and of the radiotherapy-associated angiosarcoma, all patients had a complete or partial response after neoadjuvant chemotherapy, but no conclusions about survival could be drawn from this study. So surgical resection is, of course, the mainstay of treatment, where we ablate all irradiated skin, and no breast-conserving strategies are possible. So we remove all radiated skin, like here. And this is an example of a patient that has been treated by neoadjuvant chemotherapy. You see a nice clinical response. We remove the whole breast with irradiated skin, and the plastic surgeons help us to close this wound by using a latissimus dorsi flap and advancement of the belly. I looked at previous results in studies investigating neoadjuvant chemotherapy, and this is from the Memorial Sloan Center, where they treated 29 patients with neoadjuvant chemotherapy, and they compared it to a group of 147 without neoadjuvant therapy and then performed surgery. And what I think is interesting is that in all patients which received neoadjuvant chemotherapy, there was no margin positivity found, which was occurring in the patient that had not been treated before. And also there was a difference in the development of distant metastasis, which was significant. There's another institutional cohort group described in data from the Ohio State University, and it's a little bit mixture in this group. They had two cohorts, neoadjuvant treated cohort with paclitaxel and a surgery first cohort, but they also included primary breast angiosarcoma and radiation-associated breast angiosarcoma. And there's a slight difference in tumor size, and the neoadjuvant group had larger tumors than the surgery-only group. But they found a large percentage of margin-negative patients in the neoadjuvant group, almost 92%, and 75 of them had complete responses. And it also looked at survival plots, and they concluded that neoadjuvant chemotherapy for breast angiosarcoma is associated with higher rates of pathological response and margin-negative resection, but they couldn't show any overall survival differences in this study. But that can, of course, be because the difference in size in the two groups. We know that the larger the tumor, the worse the survival. And also because there were different subtypes. So, however, in my institute, since 2018, we started treating patients with neoadjuvant paclitaxel, as was mentioned also by the previous speaker. And we did compare this treated patient with a historical cohort. So as you can see, from 2014, there were 13 patients that were treated with neoadjuvant chemotherapy. And the sizes of the tumors were comparable, and they have also been treated with extra radiotherapy and with hyperthermia. We did a response evaluation, and we found in almost all patients a clinical response, and also radiological response was found in the large group. And if you look at the pathological response, we saw a complete response in almost 70% of these treated patients. And you can see in the picture here that there's a nice clinical response, that there is a response on the PET scan with a decrease of uptake. And you can see on the MRI that the thickening and the enhancement also decreased. We also looked at the survival data here. We had a follow-up of 36 months. And we looked at 3 years local recurrence-free survival, which was 100% in the neoadjuvantly treated group versus 63 in the surgery-only cohort. Also, there was a big difference in the development of metastasis after 3 years. and the overall survival was 100% after 3 years compared to 56% in the surgery-only group. I have to say that there was one local recurrence in the group after 6.5 years. So we showed in this cohort that neoadjuvant chemotherapy with taxane, so paclitaxel, improves oncological outcomes, and we are still evaluating the role for hyperthermia and radiotherapy. I would also like to speak about another window of opportunity study that we did. And we know that propranolol is having anti-tumor activity in tumors. And what we did is we treated in a window of opportunity study patients with angiosarcoma during their waiting time until standard treatment with propranolol. And we treated 14 patients, and there was stable disease in a lot of them, but there were only 2 with the clinical benefit of the treatment. But it was, I think it's nice to show you these figures that there was really clinical in one patient clinical decrease of the tumor, and also on the PET scan, but was not shown to be clinically efficient. I also wanted to talk about isolated limb perfusion, which I don't know if you are all familiar with that technique, but we use this technique in, for example, melanoma patients to avoid amputation. We use a melphalan and TNF-alpha based technique. And what we do is we make a system of the extremity using a tourniquet, and then we use extracorporeal bypass, cannulating the arterial and venous vessels. And the blood is oxygenated, and there's a roller pump and heat exchanger, and we give a high dose of the chemotherapy only in the leg. And we can exclude the foot to prevent neuropathy. And we can give pretty high doses of the chemotherapy. This was a picture I took today on the OR. So we need a lot of space with all the machines, and also the nuclear medicine is measuring the amount of chemotherapy that's leaking through the body. It cannot be too high. We did a study in angiosarcoma that were treated by IOP between 1991 and 2016 from prospectively maintained databases, again in Rotterdam, the Royal Marsden, and our institute in Amsterdam. And we looked at local progression and development of metastasis and survival. And there were 39 patients in this cohort, and there were sporadic angiosarcoma, but a lot of Stewart trees, of course, because they occur in the extremities, and some radiation-associated tumors. And there were 23, so 59% of this cohort who had a complete response, and 10 patients who had a partial response. And here I wanted to show you the results of one of these patients who had a very large angiosarcoma on the leg, and it responded some months. It always takes some time to respond after the treatment, but it completely disappeared later on. We also looked at the survival data here. So the median time to local progression was postponed from 7.3 months to 14.5 months. And also the median time to systemic therapy in this patient was postponed from 14 months to 81 months. So we calculated the response rate for IOP for advanced angiosarcoma, 85%, with a complete response rate of 59%. And it's significantly correlated with the lower local recurrence, local progression and recurrence rate, with a trend also to better overall survival and a limb salvation rate of 87%. So it's an interesting technique. I think this is something Dr. Wagner also touched upon. So it's a little recapitulation, but there might be also in the future opportunities using immunotherapy in sarcoma. This is a large study in 2,500 sarcomas of all kinds of subtypes, and they looked at mutational burden because this is known to be high in tumors that do respond to immunotherapy. And they found that many angiosarcoma have a high mutational burden and might be good subjects for immunotherapy studies. And at ESMO 2024, there was this presentation by Dr. Wilkie who showed that in a heterogeneous sarcoma population, there was activity of this combination of PD-1 inhibitors, and she saw an overall response rate in cutaneous and visceral angiosarcoma of 39%, which is actually pretty high compared to other sarcoma. So this is interesting for the future, and I hope that there will be trials in the future. And then I like to conclude, and I'm happy to take any questions, and this is my team in Amsterdam. Thank you.
Thank you very much, Yvonne, for this amazing talk. Are there any questions from the audience first? Let me see from the chat. For now, I don't see anything. Yvonne, I would like to ask you, indeed, we have many, some evidence that neoadjuvant can help. The question is, which percent is not responding? I mean, when you start from your study, from this cohort, what percent did not respond? And the second is anyone deemed inoperable during the neoadjuvant treatment?
Thank you for your question. So I would like to show the slide again, but in our cohort, there were 4 people that had stable disease, and there were no patients that actually progressed during neoadjuvant therapy, and it was very well tolerated. So I think you can always try it. And there were no patients that were inoperable during neoadjuvant chemotherapy. So we had a pretty good experience with that.
Okay.
Yeah.
So that's really important, because for the neoadjuvant treatment, the fear of the surgeon is if it progresses and then is deemed inoperable.
Yeah, it's not in our experience, but I think, what would make angiosarcoma inoperable in your opinion? If you get lymph nodes, or if it's too extensive?
Extension may be deeper, especially in patients that have mastectomy and then radiation, then mastectomy, keeping the skin.
Okay.
And then maybe deeper in the
You
the
need to do a
ribs.
thoracic wall surgery.
Thoracic wall,
I
but
think
it's
it's
not
very rare.
Yeah.
Yeah.
Okay. And the other question I have before going to Nikos Vassos is are you removing the whole irradiated area irrespectively of lesions?
Yes.
Yes.
Yes. So I would always recommend to remove all irradiated skin, because you might develop another angiosarcoma later on. So we remove everything that has been exposed to radiotherapy. Yeah.
Thank you very much. Nikos?
Thanks. Hi, Yvonne. Thanks for accepting our invitation. And it's a really nice talk, and it's a really demanding issue, especially actually for surgeons. My question is, if you have post-radiation angiosarcoma of the breast in a field that has been already performed a mastectomy, so you have practically lesions on the thoracic wall in the area of mastectomy, and you have a small lesion on the other side of the other breast, which is still existing. this would be for you a contraindication for surgery? And if not, what kind of surgery would you perform? A mastectomy on the other side too?
It's an interesting question, but in the Netherlands, I don't see patients who have, I mean, most of the time radiotherapy is only given to patients who have breast conserving surgery. So we do not see a lot, we don't give radiotherapy after mastectomy that often. So actually, I have no experience with this, but I think if you conquer this and you have also a lesion in the other breast, yeah, I would consider to, I mean, just look at the radiation field. If that has been in the radiation field, then, but I doubt that the whole of the other breast was in the radiation field, right? So then you can maybe be more conservative on the other breast, removing the small nodule.
Okay, yeah, of course. I mean, we're talking about cases that are, let's say, quite old-fashioned in terms that actually, of course, we don't meet every day. Mastectomy, complete mastectomy for breast cancer, and radiation. But this actually used to be actually the case like 10 days or 10 years ago, or something like that. And we still have extremely rare cases, that appear angiosarcoma like decades later. This is why actually I asked this question. And I agree with you. Of course, actually, the mastectomy on the other side is actually a very aggressive decision in these patients. And yeah, I don't think so. Also, if there is actually any oncological positive effect of this in these cases. Okay, thank you, Ivan. Thank you.
And we have another question from the chat from Evangelia Karasteriou. I'm reading quote, because angiosarcomas often infiltrate microscopically beyond visible boundaries, especially in scalp and extremity sites. How do you balance the pursuit of wide margins with preservation of function and cosmesis? Do you see any future in image-guided or intraoperative fluorescence technique for margin definition? Thank you very much for an excellent presentation, Dr. Skarji.
Thank you. That's an interesting question. Yeah. I think indeed for the scalp, it's really hard to be really radical. So what we do is always do mapping biopsies to see how large really the involvement is of the skin. And then, of course, if we find some marker that we can use intraoperatively, that would be great. But I think a lot of these patients with this very big angiosarcoma of the scalp, we do not perform surgery in the end because it's too mutilating. It's always older patients, and we most of the time decide to give chemotherapy but do not perform surgery because it's too mutilating. But I think if it's something that could receive a surgery and we do have these markers, that would be great. That's something to investigate in the future. Yes.
I don't see any other questions. I think it was a very interesting webinar, and we have excellent talks. We really want to thank the invited speakers. This is the last webinar of this year, so we'll see you next year. And I give the floor to Professor Agrogiannis and Stefania for closing the session.
Stefania, would you like to say a few words? Anyway, I don't have much to say. I would like to thank again all of the speakers, great lectures. It was really another fruitful session tonight. We had about as many as 60 participants sometime. Thank you again, and hope to see all of you attending the next webinar. Have a nice evening to everybody.
Goodbye. Good night.